So it's my real honor to give this lecture. Actually, I've never been to China, and I hope maybe someday I can go to your country and visit you. Well, my topic is highs and lows in the history of PCI, my personal opinion. As you said, I'm a cardiologist in Munich, and I work as an outpatient doctor in our cardiology practice, which is an academic teaching practice of the University of Munich. So we have many students, but I also work in a cath lab in a hospital nearby with all the catheterizations and interventions. Well, to start with, I brought you a picture from 1976. That's me. That was me, yeah. If you look at the color, this was very fashionable at that time. We did a lot of imaging at that time, but cardiac catheterization was only diagnostic. If a patient needed revascularization, all patients were referred to cardiac surgery. So no PCI at that time. So I was this age, and I was lucky to experience personally the various developments of PCI, which had a lot of highs and lows, like a roller coaster at the Oktoberfest. I hope you can come next year to the Oktoberfest. This year it's canceled, but next year we all hope it will take place again. So I will talk about my personal experience during all these years. So where do we start in history? Let's start from the very, very beginning. I think the beginning of cardiac catheterization is here. As you can see, these two French doctors, 1862, made registration in a horse, in the heart of a horse, with very rigid metal tubes. But that was, at least to my knowledge, the first time this was registered in a mammal. Do you know this guy? I'm not sure. This is Dr. Röntgen from Würzburg, Germany, 1895. He actually was detecting some strange radiation, and why it was so strange, he called it X-ray. X, we don't know. And the first thing he did, he called his wife, said to his wife, look, I found some interesting radiation. Put your hand in this radiation. So this is probably the first X-ray picture in the world. You see here the ring of his wife. So combining catheterization and X-rays, this is Forstmann in Eberswalde, Germany. In 1929, he is said he did the first cardiac catheterization in mankind, in human being. And he published this in a Munich, actually in a Munich journal. And the hospital where he did this is named after him. And I recently had the opportunity to visit the hospital. So when you enter the hospital, you see his head here, but here behind you see the catheter and the famous picture he made. Here's the original picture of the cardiac catheterization he did by himself. And what you see here, it stops at the right atrium. So this is not a coronary angiogram. This is just an introducing in the right atrium, because this was a urinary catheter. Of course, there was no cardiac catheters around. And I think he was lucky that the catheter was too short, because if he would have put this rigid catheter in his right ventricle, he may have possibly fibrillation. It will not have survived it. So he was lucky to be there. Interestingly, this was his boss, Professor Sauerbruch, and his boss' comments were, with such a stunt, you can get your appreciation in a circus, but not in a decent German hospital. So he did not recognize actually what he did. And in 1956, this stunt in the circus, actually, he became the Nobel Prize together with André Cournot. Probably you know the Cournot catheter. But who did the first coronary angiography? This was a couple of years later, 1958, by Mason Soanes in the USA. This is an interesting story too, because this was not his purpose. He did not want to do coronary angiography. Actually, coronary angiography was forbidden. It was strictly forbidden to enter with a catheter, the coronary. He wanted to do aortic root angiography. And inadvertently, he came into the right coronary, but instead of being frightened and pulling back the catheter, he made a picture, and this is why he got so famous. So the first right coronary artery, the first coronary artery at all in 1958. Looking at the history of coronary revascularization, of course, you know the Weinberg operation. But what is very interesting, this was 8 years before the first coronary angiography. So what did he do? He didn't know about coronary lesions. He didn't know. So what he did, he put the mammary artery, the lemma, into the myocardium, just diffuse. The blood was not anastomosed. The blood was diffusely flowing into the muscle. And this probably helped a lot of patients. But several years later, in 1967, from Argentina, the Dr. Favoloro, he is said to have done the first coronary bypass surgery. And interestingly, he also got a postmark, $10 here, to remember his great, great success. So then in the early 70s, this guy, you mentioned him already in the introduction, Andreas Grünzig, he came along and he said, what's going on here? Why should we open the chest just because of a problem which is only a few millimeters? That doesn't make sense to him. So he was thinking of another way. Well, he was born in Dresden, in East Germany at that time, and he escaped East Germany, going to West Germany. And there he met a lot of doctors. And I think one of the most important people he met was Charles Dodder. Dodder at that time was a famous radiologist, angiologist, doing PTAs, peripheral angioplasty. But his technique was bouginage. I'm not sure you know the word. I had to look it up again myself in English. So bougian, we say. Bouginage means that you open up a vessel by always introducing a larger bore, like small starting here, getting larger, larger, and opening up. But Grünzig said, no, this must be easier. So probably he invented the balloon, which you need only one device. As you know, you put it in and blow it up. So for PTCA, he said we should do rather with a balloon and not bouginage. So this was the famous day, September 16th, 1977, the first PCI. Here's the lesion. Here is actually 2 days later. Doesn't look so great here, but 1 month later, the follow-up angiography was very nice. And interestingly, the patient at that time was 38 years old, but he came back in the year 2000 when he was 61 years old, and he had a control angiography, and it looked just fabulous. No stent at that time. Some people say, some critic people say, maybe the first PCI was not a real lesion. Maybe it was coronary spasm, why it looked so great after so many years. Well, more or less, it was a really great performance. So he didn't only do these things, he was very, very anxious to distribute his knowledge. A lot of lectures and posters, talking to people. And this is a very famous picture from the wall here where they're sitting together and everybody was reporting his results. So for example, Minneapolis, USA, did 3 cases, 2 were successful, 1 was successful. Freiburg in Germany did 1 case, had 1 success, so they had 100% success rate. So they were really very, very anxious to exchange their experience. Where do you get the balloons? The balloons were handmade. Each balloon were handmade in this kitchen. There was this famous kitchen here in Zurich in Switzerland. Why in Switzerland? Because Grünzig had to go to Switzerland to do the first PCI, although he was in Germany, but in Germany, nobody was interested. So Germany missed this historic opportunity to do the first PCI. So in Zurich, in this basement, these were the tubes and the balloons. And this lady, she was producing, manufacturing each balloon, manufacturing self. Well, he was a very, very compassionate pilot. And unfortunately, when he went to the United States. He died on October 17th, 1980, in a plane crash. He was the pilot himself. It was a big thunderstorm, and he just had this accident. Some people, even his brother is still alive. I know him personally. He's an eye doctor. His brother is convinced that he was killed because he held patterns of the balloons. Well, we don't know. There is no proof, but these are the histories. So if we look at the problem and the solution, like here, the problem was avoidance of a thoracotomy, which was achieved by balloon dilatation, which was the first of many, many hurdles the history of PCI had to cope with. Then another problem came up, dissections, which at the beginning people did not expect. Why? Because the was that with a balloon you compress the plaque like this, but this is wrong. Usually, as you know, the plaques are like stone, they are hard, so you cannot squeeze the plaques. There was the wrong assumption for PDCA, but you push the plaques into the wall, and then of course you get dissections. And there were many dissections at the beginning. This was actually a terrible experience. And if you look at dissections with ultrasound, for example, it looks really terrible. The question is, what would Grünzig have done if he would have had the IVUS? Probably if Grünzig would have IVUS, he would have stopped all his efforts to do that. Well, but luckily Grünzig did not have IVUS, so he continued doing this. So what was the solution of dissection? This solution was the same as the coal miners do. They put in scaffolds to prevent the mountain of falling down in the tube. So we did the same, developing these scaffolds. At that time, we called them, of course, stents. And this is the first stent implantation in 1986. Interestingly, 9 years after first PDCA. So PDCAs were done 9 years without stents. Can you believe that? Unbelievable for us. This lady was 51 years old at that time, and you see the nice result with the first stent. Professor Siegwart in Lausanne, again, Switzerland. It's interesting, Switzerland was really pioneering this whole field. And this is the lady who got the first stent. By the way, do you know who this is? Probably you don't know. This is Charles Stent. He lived 1845 to 1901, and he was a dentist. So why is a stent in cardiology named after a dentist? Because he did these scaffolds here. When we put in stents in patients, probably if you look at the result, it looks like putting in your teeth into such holes. So the solution for dissections were metallic stents. Great, this was the second hurdle. Is it over? No, it's not over yet, because Professor Siegwart already 1 year after putting in the first stents, he said, we need long-term follow-up. Maybe he felt that something is not going the right way, and indeed it was not going the right way. We created a new disease, which is coronary stent thrombosis. And this is really a spoiler of the game, I would say. Stent thrombosis is really dangerous. At that time, we had 25% stent thrombosis. Can you believe that? People died, sudden death, sudden death, sudden death. So people were upset and said, stop putting in the stents. We cannot go on like this. And since stent thrombosis usually leads to a heart attack, the mortality was up to 45%. And the surgeons were upset. The surgeon said, stop doing this, refer all the patients again to surgery. You cannot continue like this. And it was really terrible. I remember what we put in: heparin, vitamin K antagonists, dipyridamole, all anticoagulation drugs. People got terrible hematoma. This is how people looked after stent implantation. And we could not go on like this. Until this famous genius from Italy, you know him, Antonio Colombo, he said, well, let's look into the stents, what's going on there. And he discovered that usually the stents were under deployed. So he said, we need higher pressures. above 14 atmospheres up to 20 atmospheres, which was a lot at that time. So using higher pressures, higher implantation pressures, was solving one part of the problem. The other part of the problem at that time, we had to realize that the stent is naked. It's a foreign body, and it needs time to get endothelialized. And to bridge this time for complete endothelialization, people came to the idea to use dual platelet inhibition, DAPT. So in addition to thromboxane inhibition by aspirin, we had P2Y12 antagonists at that time, clopidogrel, later on, prasugrel and ticagrelor. But at that time, in the 90s, late 90s, and in 2000, there were 5 studies, 5 randomized trials showing clearly that dual antiplatelet therapy is much better than anticoagulation. So what does the stent do? The stent actually creates an activated platelet, thrombus, from acquired platelet, and DAPT is interrupting this process. If we look at the development of PCI in Germany, you see that actually here, the higher inflation pressures and dual antiplatelet therapy, they were really the condition that it took off like a rocket. These are the latest number of PCIs in Germany, 360,000 in the year 2019. So without that and without high inflation pressures, PCI would have died. So this was actually the third hurdle. And you might think, okay, now it's over. But there were many, many innovations. The first Grünzig catheter, I used it myself, was very, very difficult to use because you did not have a separate guide wire, which we are used to then. Then Simpson invented the long wire technique over the wire, and then Kaltenbach with Bansel from Germany, they invented the monorail catheter with shorter wires, which really made single operator procedures much easier and made our life also much easier. Another group here in Germany, friends of mine, they had the idea of direct stenting because we had always to manually crimp the stent. And for direct stenting, the stent must be fixed in some way in a balloon. So this was a special balloon for fixing a stent, not to get dislodged. And of course, today you don't need it. But at that time, in 1998, it was a great idea. Then movie storage. We used first film, analog, and then as super VHS, and then of course computers with different compression rates. We did a study at that time looking at different compression rates and the image quality. This was double-blind study. We came up with these compression rates, but later on DICOM standard changed the world. There was a unified standard all over the world for this. Well, one of the big problems was holding pressure. With all these anticoagulation drugs in the early 90s, we needed sealing devices. And here we wrote a paper on the various sealing devices. Actually, we used the DUET trial. We did the first patients in the world, published this in the American Journal of Cardiology, which was a very nice solution for not holding pressure anymore, but sealing up the artery. Then AngelSeal came up. We had a lot of experience with AngelSeal. And actually, I did this myself, my first patient, 1998. I happened to occlude the common femoral artery. And we published this. You also have to publish your complications, not only your success rates. Some people told me later they also happened to them, but they didn't publish it. So maybe I published the first common artery occlusion. And you have to just get experience with this device. So things are over? No. We got a new problem, which is called in-stent restenosis, a new disease. We cardiologists were really great champions in creating new diseases which never existed before. And why is this? Because the stents are good. They have a good part. They avoid shrinking, but they also have a bad part with a foreign body. They are a foreign body, and the body does not like these things. So what does the body do? We call it keloid. This is a tumor, like this one here after piercing the ear. This tumor occurs. And this is very similar how instant restenosis occurs. So stenting is like piercing a part of your body, and the body just kind of reacts with this tumor. At that time, we called this the Achilles heel. You know, Achilles had this vulnerable heel. This was his problem. And again, the surgeons were saying, you cannot go on like this. Why? Because PCI, at that time, we had only bare metal stents, had considerably more events than bypass surgery. So it was very difficult for us cardiologists to continue with PCI, and we tried everything. We tried laser, rotating knives, drilling. Yeah? Sometimes the cath lab looked like the construction site with all these instruments. It all did not help. Why did not help? Because, as I said, instant restenosis is not a theroma, it's a keloid. So what you do, physicians, when they want to treat a keloid, they do radiotherapy. And we did this by intracoronary brachytherapy. This is how the cath lab looked, radioactive in front at the entrance from the cath lab. And it was a little bit difficult to handle. You need radiation physicists and radiation therapists in the cath lab to prepare all these devices. But then the application was rather easy. You just, with a syringe, put in the pellets. Of course, the radiation therapists has to be present, and brachytherapy went all over the world. It was the first scientific method to solve the problem of instant restenosis. But then Voltaire said, probably he said that, better is the enemy of good. And this was the case here too. The better was to avoid proliferation from the beginning instead of treating cell proliferation. And this is how drug-eluting stents came on board. The struts, the bare metal struts, got a coating, and the coating had a drug, an anti-proliferative drug, released into the vessel. I remember very well, it's more or less exactly 20 years ago, yeah? Marie-Claude Maurice presented in Stockholm at the ESC the Rebel study with a bare stent randomized with a Cypher stent, and there was 0% restenosis in the Cypher group, and we all knew this changed the world. It will never be the same again. Of course, 0% could never be repeated. There's always a number of instant restenosis, even with drug-eluting stent, but this changed everything, and this ended up actually the brachytherapy. So the new disease, instant restenosis, was treated first by brachytherapy and then by drug-eluting, which I would call the fourth hurdle. Was this the end of all these nightmares? No. Nightmare started. So what happened? So in 2006, this guy said, stop putting in drug-eluting stents. You are killing patients. They increase deaths. Why was this? Because of many, many registries showing that there's a continuous increase of late and very late stent thrombosis with Cypher stent, with Taxus stent at that time. And this is, of course, a bad feeling when you put in a device forever. You cannot take out a stent. You cannot recall a stent. It's there forever. And you have a permanent problem here. So these were the stents of the first generation. And if you look at the animal data, the bare stent was healing in much better than the Cypher and the Taxus. This is why it was wrong at the beginning to go only for 2 or 3 months depth with these drug-eluting stents. So we had to increase the duration of depth for more than 1 year, hoping that it will avoid late and very late stent thrombosis. But then luckily, new drug-eluting stents, newer generation came on board, which were healing close, very similar like bare stents. So we could again go back to shorter depth durations. We were lucky, actually. I participated in the Resolute all-comer trial, which compared the Resolute sotarolimumab eluting stent with the Xience V everolimus eluting stent, and the target lesion failure was comparable. There was no significant difference in late stent thrombosis, and luckily, very late stent thrombosis was also very low and comparable. So we were lucky with the 6 months. depth duration, but then the theory of secondary prevention came on board with long depth, lifelong. And people said, are you crazy cardiologist? Do you know what you want? The referring physician, the general practitioner said, why are you changing your mind all the time? First you say short depth, then long depth, then you go back to short depth, and now you go back to long depth. This is difficult to understand, but with secondary prevention, long depth makes sense. So how low can you go? How low can you go with the depth duration? Just a couple of weeks ago, there was a hype at the ESC with the master depth trial. 1 month is enough in these patients. But remember that the science stent, this was the Ultimaster from Terumo, but the science stent also has the approval for 1 month. And in 2013, by the way, if you think back, the Resolute stent got also the approval of 1 month of dual antiplatelet therapy. At that time, we were not so innocent. We also participated in the trial, published this in the European Heart Journal in 2014. And what we saw was very astonishing. The stent thrombosis is very common if you discontinue depth in the first 4 weeks. But then actually, it's only a little baseline. So the first 4 weeks are the one which is very important. And as the guidelines recommend, do not discontinue depth within the first month. For any reason, continue at least for 4 weeks. And with some stents, it makes sense if there's a reason to stop depth after 4 weeks. Well, other progress were radial access, getting a 1A recommendation as the standard approach, which was a really high in the PCI. And then the introduction of FFR to stent or not to stent was very, very helpful. We did a little study comparing adenosine with regadenoson. So with regadenoson, you get similar results, but the patient has less side effects. This is a normal FFR. You would not stent the lesion. This lesion has a decreased FFR with adenosine. With regadenoson, of course, you would stent the lesion. So the question was coronary intervention or bypass surgery. People don't like to get to surgery very easily. So I had the big honor, 2005, it was really one of my highlights of my life. I was the chairman of the first guidelines of the European Society of Cardiology for PCI, where we also made recommendations who should get a stent and who should get surgery. Here are the stents which we recommended. Actually, only these 12 drug-eluting stents were recommended. But bioabsorbable scaffolds, what happened to these? We did not recommend till today. Why? Because the concept is great, but as you know, the results with the bioabsorbable absorb stent after 5 years are unacceptable. 5-year target lesion failure, 5-year device thrombosis, much higher with the scaffold, with the resorbable than with durable stents. And another study said, well, we have to improve our implantation technique, the AIDA study, but unlucky, this came to similar results with much higher thrombosis rates, definite or probable in the scaffold than compared with the durable, and late and very late stent thrombosis. So the bioabsorbable plastic stent, I would say, has no role today until we get more data. What is the alternative? The magnesium bioresorbable stent, introduced 2007, and the latest data here presented at the ESC were rather promising with similar late stent thrombosis and stent thrombosis with the advantage of the magnesium stent. But if you look at the device-oriented clinical endpoint, it was not so promising. So far, I don't see a really role, and I hope we have the key in the future, because I still believe in the concept. We need absorbable stents, especially because we are doing a lot of non-invasive coronary angiography with CT. And with CTA, the stents have to dissolve so you can better judge the vessels with the CT. Well, what's the future? I don't know. And I finish my talk with this famous idiom from Niels Bohr. He was a Danish physicist. And he said, it is difficult to make predictions, especially about the future. Thank you.